And now it's my pleasure to ask our next presenter, Dr. Huang, here from the University of Singapore. And Dr. Huang is associate professor here at the university at the Department of Obstetrics and Gynecology. He is also Deputy Director of the NUS Bioeco Asia Center for Reproductive Longevity and Equality, specializing in the research of women reproductive health, aging, digital medicine, and leading the conversation in women's reproductive longevity and equality. So he will present some information today on defining severe LH and FSH deficiency in patient management. So now we go from the normal patient to the more problematic ones. So yes. Thank you very much, and stage is yours.
Thank you. Thank you, Prof. Fisher. So thank you, Prof. Fisher, for the nice introduction, and also thank you, Prof. PC, for giving me this very clinically relevant and extremely challenging topic to talk about. I thought Prof. Fisher should be talking about this topic because I learned so much from you, and I'm also quoting your reviews and recommendations. So please allow me to share this very interesting topic. I just want to declare that I got a research grant from Ferring Pharmaceuticals. Again, this is just purely academic and no other relevance. So basically today's topic, well, what I'll be discussing about is really the definition of FSH and LH deficiency. So I have some esteemed colleagues amongst the crowd will be asking, what is FSH and LH deficiency, right? So this is something that I will attempt to discuss with whatever that is known currently. And I think most importantly, all of us who are practicing clinicians, as well as embryologists among us and nurses, you need to understand the physiological aspects of FSH and LH. Well, how these two hormones actually act on ovarian follicle genesis. So this is something that will help us understand why we're using the drugs we're using, understanding why we are starting this, and having the outcomes that we are looking at. And I think the implications of FSH and LH deficiency during assisted reproductive techniques is really something that we need to take note about, because there are more and more clinical studies that have come about that perhaps, there's something we can do and we can find out more from our patients that we're looking after. And finally, I think most importantly for all of us who are practicing clinical IVF is to manage FSH and LH deficiency during ART itself. So if you could, just some starting questions to see where we are all at the beginning. So the first question, oops, is that appropriate? What is observed in women with FSH and LH deficiency? So something quite basic. But what do you think we expect to see with FSH and LH deficiency? This should be quite quick for everybody. Now this is a little bit interesting because the answer is supposed to be low estradiol. So we need to correct some physiological understanding of this phenomenon. So good to know. Oops, am I going next? Yeah. So next. Again, something very basic I mentioned. Where are LH receptors not found? LH receptors are not found on which type of follicles? Apologies, because if you're talking about AMH, ovarian reserve, you should also know where these LH receptors are found. Anybody? Okay, let me just, oops. Okay. Oh, this is great. So you're all correct. So most of you understood that the primordial follicles are the ones that are non-gonadotropin sensitive. So they're the ones that are truly the ovarian reserve. That at this point in time, clinically, we can't define the exact primordial follicle pool, right? So they're the ones that you do not find LH receptors, but there's still some of us that are still a little bit confused. So we will try to address that later on. Okay, and I think the most important part is the definition. All of us, when we train in medical school, we always ask that, what is the definition? And in this case, it's very unique because it's only for us, for other clinicians, that this makes a lot of sense. So gonadal failure associated with reduced gametogenesis and reduced gonadal steroid production. And this is due, the word is important, it's reduced gonadotropin production or action. So there's not really a lack of. So I'm not going to talk about hypogonadotropic hypogonadism from all the other, etiologies that you can look up in the textbooks. But this is a different phenomenon, and this is something that we got from the International Committee for Monitoring ART. And classically, the characterization of LH and FSH deficiency is reduced LH and FSH production or action. So the word is reduced, it's not non-existent, right? And you can actually have normal low LH and FSH, but you have low E2 levels. So the estradiol levels actually make a lot of difference. Okay, so the reference for the paper is there, so I hope you have a look as well. And importantly, when we go back to about, when we start out reproductive endocrinology and why we do IVF, it's all back to basics. So this is the definition, so you can see all esteemed panelists and speakers are all here. Prof. Carlo is here. So basically, it all starts from the brain, right? So you have pulsatile GnRH secretion. Thereafter that, it goes to the pituitary, anterior pituitary. In that case, when we teach medical students, we tell them anterior pituitary. That's very important. That's where FSH and LH is. And this will actually act on your ovarian follicles, the follicles that have FSH and LH receptors are sensitive to it. And then finally, you have all the downstream effects. All right. So all these part processes, there are a lot of molecular biology things which I'll not bore everyone here. But this is something that can happen. And what we talk about, poor response, as well as the issues with all these genotypes, variants, and whatever. These are all part of the process that we need to understand. And I really want to quote this paper, which I think Prof. Fisher has also quoted before, explanation. And I think this is a very interesting paper because these are actually derived from human antral follicles, okay, throughout the entire folliculogenesis process in women. Okay, and what I want to take note is that even from very small antral follicles, so that we see on scan, we started to measure our antral follicle counts, about 6 mm, you notice that actually there's presence already of LH receptors. So they're all starting to get sensitized, okay, to your LH itself. And of course, your FSH is already there in high levels. Okay, and the other genes, aromatase and all this, trying to result in the expression of genes to produce high levels of estradiol during the follicular phase itself, folliculogenesis, as well as during the stimulation cycle. So this part is really interesting to me because if you do see that the amount of LH receptors actually gets more and more, but it's persistently present. Okay, and of course it's highest prior your pre-ovulatory state follicles. And your FSH actually decreases. But hey, during our IVF stimulation, we don't really decrease the FSH stimulation, isn't it? We just continue the dose. So this is something that we need to understand, that the follicles really are quite unique and different during each cycle itself. And perhaps that explains why there's some asynchrony, there's some discordance in the ovarian follicle stimulation as well. And just to take note, LH appears to affect human follicle development during most of the follicular phase, even in normal women. Okay, so not just in women who are really the more older ones, or women with other issues as well. So what are the implications of FSH and LH deficiency? I think what is most important in that, as IVF clinicians, reduced or absent follicle development is very, very sad. Okay, to have a cycle cancellation is even worse. Okay, and next is, I'm not everyone here will use to measure serum estradiol levels. But I know even those very senior experienced clinicians amongst us, they will always start with a baseline estradiol level. And then when they start off the dosing, initially at day 5 or day 6, they will also measure the E2 levels just to ensure that the follicles are actually responding and are growing. So I think that's very sound clinical practice. There's a lot of data that shows that if you're a very good sonographer yourself and you do the scans yourself and you trust the scans, okay, perhaps, you could trust on your finding based on scan alone. But if you add on estradiol, this could help you a lot in your diagnosis. And of course, this is what you could find online and everything, but something functional, which is the main cause of FSH and LH deficiency. Things like anorexia, excessive exercise, eating disorders. And importantly, when we talk about the Poseidon criteria and everyone who's in the older age group, the age-related impairment of GnRH pulses, these are all functional. And hence, which we'll talk about later on, why certain groups of women may benefit with LH support later on. And not to mention the other organic causes and the iatrogenic cause. And this is something that I want to emphasize also, that GnRH analogs that we ourselves can actually cause LH deficiency and FSH deficiency. Okay, so these are two published studies that are rather recent that I put it up. And I think what I'm trying to show here is that one is published in 2015, an Australian group. The other is in a Chinese group in 2022. What is really, really important to show is that this study shows that actually in more than half of the cycles during antagonist protocols, which most of us are using because it's shorter, happier for patients, less injections. What happened during this period of time is that there's very low LH levels throughout. And they found out that with LH supplementation, okay, this actually helped in many of these cycles being supported and having better outcomes, which is all what we want. Okay, so, and I'm glad to say that we have also some Asian representation. I'm not sure amongst those experts around us. Do you see any differences in women who are Asians versus Caucasians? And I think Dr. Andrew Khan may have his own take as well. There may be some differences in how these women respond as well. So I think it's important that as we move along, having this in mind, why we may need LH supplementation, especially when we're using certain protocols as well, may help us, to give rise and think through why certain protocols work better for certain women and not others. And the other thing is that I'd like to emphasize the word here is older women, and I'm very sorry that I keep using this word older women for the lady audience amongst us. But this is something that we have to keep talking about, because we do know the effects is quite different. And what is difficult is the definition of what is considered as low LH. Okay, so this LH, if it's the baseline or is it after you started antagonist cycle, what we notice is that overall in women who are above, okay, or in this study groups and the control groups, they actually measure women that are way beyond 36 years. They're all on average about 38 years old. And in this group of women, we notice that, there is important of LH supplementation. So there's enough evidence to suggest that if a woman is getting older, is above 35, you really do need to give LH supplementation for this group of women, just for the fact that from physiological point of view, there is some age-related differences. And it's following here, that's where we see all this data, when we notice that the difference is that they all remain low even before GnRH administration, and following after that, it get even lower. So these women are even more sensitive to our antagonist protocol, and hence they will need LH supplementation throughout the IVF cycle. Okay, now how about poor responders? I think I don't need to really emphasize a lot about poor responders, but in this particular group of women, we know that in one of the latest studies as well, and we see familiar names again, LH supplementation of ovarian stimulation protocols really influence the follicular steroid composition and may contribute to improvement of ovarian response in really poor responder women. So that, I think we have a whole long discussion this morning. And I think that, again, based on all these studies put together, it is no wonder that, in poor responders, we should really consider and should start using LH supplementation. And also primarily because they need LH. In a sense, they probably have LH deficiency, or the action of LH is really deficient in this women itself. Now, I would like to challenge a little bit as well, because, in some of our centers, we are seeing bigger and bigger women who are actually starting to do IVF cycles. How about women who are obese? Does it make any difference at all? So again, this is a relatively recent study. And this is looking at the effect of recombinant LH addition to recombinant FSH, okay, in overweight and obese patients without polycystic ovarian syndrome. So we're not talking about women who are PCOS and are sort of associated with obesity, but in women who are actually considered obese, okay, and what are the effects itself? So over here, what we noticed is that ongoing pregnancy rates in obese and overweight patients were still significantly higher in recombinant LH added group compared to our FSH only groups. No one really knows the exact answer, but importantly, what they've noticed is that it's shown that obese and overweight non-PCOS patients has lower endogenous LH levels. Okay, and in this case, if you look at the definition of what is considered obese, it's all classically above 25. Okay, and I'm sure some of you will see bigger women, especially in Singapore, we do see a lot of women above 29, even 30. That's not unusual at all to see in our center here. So this is something that we can consider. There is some evidence, but again, we will need more studies, but something to think about, given that there are already some clinical evidence that suggests this. And finally, when we talk about clinical management, in view of time, I will have to summarize as much as I can. And I think Prof. Carlton is all over the place, and Prof. Robert as well. His name is here. So I'll just summarize that patients with sufficient pre-symmetric ovarian reserve parameters that have an unexpected hyporesponse to FSH monotherapy. In these cases, HLH can be started during the mid-follicle phase to rescue your ongoing cycle or on stimulation day 1 in a subsequent cycle. Okay, so this is quite clear. You can start mid-cycle or you can consider starting from day 1. And of course, in women who are older, above 35, okay, the positive effects in terms of implantation rate, okay, is observed in donor cycles. Okay, so there are some evidence that we should, in these populations, to really consider in view of their physiological needs for LH support during an assisted reproductive cycle. And I think this is something that Prof. Carlo was actually alluding to just now, addressing to some of the questions. When do we start? You know, is it day 1 or day 5 or day 6? So this is the randomized controlled trial, which was ended a bit earlier because they couldn't see any obvious difference in the outcomes, which is more superior than the other. But what they observed is that there's no difference whether you start in day 1 or day 5, day 6 in terms of increase the number of eggs or more eggs or less eggs, oocytes in terms of that sense. So to me, personally, my own take is that I've been practicing now more and more starting LH from day 1. And I think the outcomes are still very ideal, especially in a selected group of women. They're still getting pregnancies and getting blastocysts as well. So I think something to consider and think about, something we can discuss as a group further. But I also like to add this in is this clinical management for all? To all women, are all women really truly FSH and LH deficient? Should they all be just given recombinant LH? Everybody just get it. So this is something that is quite interesting. I just got it recently from Journal of Clinical Medicine. It's not very high impact, but still some clinical studies are that have shown some differences. Okay, and it's showing because it's a real life analysis. As you all know, in IVF itself, because we really can't age match or match everything exactly the same, RCTs are really hard to conduct. And therefore, given this real life analysis, it seems to show that, even in suboptimal normal responders, it still represents a reasonable option for patients, okay, with predictable, unexpected poor or suboptimal response. And again, in normal responders, there's something that they couldn't really find an obvious difference or clear difference in that. So really, sometimes we need to start the patient on their first cycle, given what we know, and then see how she progresses. But of course, there's a lot more to learn and discuss. And therefore, this is something that I hope that we will get to learn more, and really from real world data as well, because this is where we get the real scenarios and the real cases. So in summary, what I want to share is that FSH and LH deficiency is not uncommon and actually very common in ART cycles. Physiological aspects of FSH and LH on ovarian follicle genesis is particularly affected in older women, 1 in 35 women with poor ovarian response, and obese women. And FSH and LH deficiency during ART can affect reproductive outcomes adversely. And in terms of SFH and LH deficiency during ART, this can either commence from day 1 or when the GnRH antagonist started based on very limited clinical data. Okay, with that, I thank you and pass back the time.